I'm Manoj Karmakar. Welcome to ISSPS TV. In this next video, Professor Boezaart is going to discuss with us the microanatomy of the brachial plexus and their potential implications for brachial plexus blockade. If you like any of our videos, do remember to like and share them with your friends. Also, do remember to subscribe so that you can get regular notifications of any future uploads.
I am Boezaart, and the topic I was asked to present today is the microanatomy of the brachial plexus and its implications for regional anesthesia. I thank Professor Karmakar and the organizing committee for inviting me to present this fascinating topic. I have no relevant financial disclosures. The microanatomy of the brachial plexus is very well described, and I refer you to any standard textbook for this. There are, however, 3 recent microanatomy discoveries that potentially have a profound influence on how we do regional anesthesia that I would like to highlight. The first is the way that local anesthetic agents spread centrally and peripherally after intraneural injection. The second new development is the concept of the Circumnerium, formerly known as the Perineurium, and before that the gliding apparatus of the nerve. And the third is the newly discovered and recently described circumfesicular collagen layer. So let us dig into this and start with central spread after injection into a root or trunk of the brachial plexus, and let us first look at some older concepts. What happened over the past 100 or so years? Now compare this Coordinator image of 1899 with the electron microscopy image of Reiner of 2016 and notice the obvious similarities. Doug Selander in 1978 showed that fluorescent dye injected into a fascicle under direct vision spread centrally inside the fascicle. And he demonstrated the dye subpial in the spinal cord. He postulated spread via the fascicle that basically agrees with the findings of Danny Moore in 1952, where he injected India ink under direct vision into the intercostal nerve of rabbits and showed spread to the spinal cord. He attributed this spread to the presence of paraneural spaces in the endoneurium of the fascicle. He was the first to coin the phrase paraneural spaces, a concept that remained in the mainstream of our pool of knowledge for well over 60 years. In his textbook of Complications of Regional Anesthesia, he stated that intraneural injections may be dangerous, not only on the basis that they may cause nerve damage, but because solutions injected intraneurally may reach the subarachnoid space or the spinal cord via the perineurial spaces of the peripheral nerves. And he said, the perineurial spaces of the nerves are actual, not just theoretical avenues to the spinal cord when solutions are injected intraneural. And even in Reiner's 2016 atlas, some, including yours truly, believed that the perineurial spaces could be seen outside the myelin sheath in the endoneurium of the fascicles. What we at the time thought were perineurial spaces could comfortably explain central spread, until Professor Reiner himself demonstrated that these spaces that looked like perineurial spaces were in fact artifacts caused by the preparation of the electron microscopic specimens. Let us now look at some new concepts of central spread. We now know that there are 6 avenues for intraneural injected fluid to reach the central nervous system. The paravertebral nerve roots of the cervical, thoracic, lumbar, or sacral spine brings a sheath of meninges with it for varying distances. And Moore in 1952 and Labat in 1923 aspirated CSF from these subarachnoid spaces during attempted supraclavicular blockade. We can reach the spinal canal by any of the 6 avenues shown here in this Mary Bryson drawing. N1 is a subarachnoid injection, typically steroids injected into the neuroforamen with no serious consequences. N2, on the other hand, into the parenchyma of the nerve root or trunk, resulting in delayed respiratory arrest and severe neurologic deficits. N3, extra or epidural injections, typically when a large bore TUI needle is used, leading to a perfect nerve root or trunk block. N4 depicts a subarachnoid injection with immediate respiratory arrest and no neurological deficit if properly ventilated. N5 is also a subarachnoid injection into a paraneural cyst or arachnoid villi with similar effects as N4. N6 is a subdural but extra-arachnoid injection leading to the so-called massive epidural. Perhaps this yet unpublished personal series from my medical legal practice in the USA illustrates this best. I was an expert witness for the defense of 14 cases of devastating or potentially devastating complications after interscalene or cervical, thoracic, or lumbar paravertebral blocks. And remember, an interscaling block is a cervical paravertebral block if done on the root or even in some patients on the trunk level. It was possible to allocate the patients into 2 distinct groups, and we added a 3rd group from our own clinical practice. Group 1 had 6 patients with late, after 20 to 30 minutes, respiratory arrest. All 6 of these patients presented post-operatively and were mechanically ventilated for 5 to 10 hours and had significant permanent neurological deficits after 6 weeks that varied from monoplegia to quadriplegia. Group 2 had 8 patients with immediate respiratory arrest. All 8 of these patients also required 5 to 10 hours of mechanical ventilation, but none of them had any neurological deficit, and all 8 made a complete recovery. There were 3 patients from our own group over a period of 12 years where 18-gauge TUI needles were used for the block. The needles were opened to ambient pressure and CSF was noticed at the needle hub. It was regarded as dural punctures and the needles were removed and replaced at a higher level and no neurological or other sequelae followed. All the blocks done for the patients in Group 1 and Group 2 where they had delayed or immediate respiratory arrest had this closed syringe tube thin sharp needle combination in common. With this needle, the dura and arachnoid of the dural sleeve can easily be punctured, and as we know, the aspiration test is totally meaningless because the suctioning draws tissue onto the needle opening and obstructs it. and even if CSF were aspirated, it would be mixed with the clear fluid in the tube and syringe and thus not be recognized as CSF. The patients in group 1, those are the patients with a late delayed respiratory arrest, all had significant syrinx formation on MRI after 6 weeks. What happened here? In the patients in group 1, the needle was placed inside the parenchyma of the nerve roots or trunk at the N2 level here. Spread was central between the fat cells and the perineural cells of the nerve fibers and needed to first diffuse through the Pier before reaching the CSF to spread cephalad to reach the respiratory centers. This spread over the Pier took some time and accounts for the delay in the respiratory arrest. The neurological deficit that followed was a function of the size of the syrinx, which in turn was a function of the volume and the pressure of the injectate. We do not know if the nerve damage is due to local anesthetic toxicity or whether it is due to the pressure and subsequent ischemia. The needle for the blocks in group 2 were placed subarachnoid at N4 or N5 and the CSF backflow was not noticed. The entire dosage of local anesthetic was then injected intrathecally deep to the arachnoid with immediate respiratory arrest due to total spinal block that lasted as long as the local anesthetic lasted. In group 3 patients, the dural and arachnoid punctures were immediately identified and no agents were injected at the site. They were regarded the same as any other accidental dural puncture. This is a patient from my own practice for whom I performed a lumbar paravertebral block. I placed an 18-gauge TUI needle open to ambient pressure and connected to a nerve stimulator using Capdevilla's landmark some 1.5 inch from the midline. CSF freely flowed from the needle hub as soon as the motor responses were observed. The needle was withdrawn and replaced a segment higher with no further consequences. Now, how does local anesthetic, or any other fluid for that matter, spread in peripheral nerves? Here are some older concepts. The prevailing wisdom as recently as 2018 was that intravesicular injections were possible and that it was responsible for nerve injury. Spread after intraneural injection has always been believed to be subperineural, subepinural, extraneural, or subparaneural or subcircumneural. This animation demonstrates the prevailing opinion as recently as 2018. Spread is via the endoneurium of the fascicles, number 1 in this drawing, and of course in the adipose tissue of the subepinural space, number 2. Let us now look at some newer concepts of intraneural spread in peripheral nerve. In this paper from our group from the Reiner laboratories in Madrid, we introduced a novel marker we called heparinized blood solution, HBS, to histologically follow the spread of a solution deliberately injected into nerves. We use this marker because it stays in the compartment into which it has been injected and does not cross barriers. With this solution, we were able to show confidently that intraneural spread was only possible between cells. The cells of the perineurium and fat cells, and only between cells and nowhere else. In this study, that was published in 2019 in Anesthesiology, it may, under low magnification, look like intravesicular spread was indeed possible, as can be seen on this image. However, it was clear on high magnification that the spread was between the cells of the septae that were formed by the perineurium. As hard as we tried and failed to inject into the fascicles, this study led us to conclude in 2019 that spread was not possible inside the endoneurium of the fascicles, and that there are without any doubt no perineural spaces in the endoneurium that allowed for the spread of local anesthetic agents. The only spread was between cells, again the cells of the perineurium, and the fat cells, anywhere where fat cells may be. Let us now have a closer look at the circumnerium, previously and still sometimes today referred to as the perineurium. This membrane, first known as the gliding apparatus of the nerves by neurosurgeon, was described in 2012 by the Anderson group. The anesthetic implications of it was quickly realized, as not even methylene blue could penetrate this membrane. It would thus take a high concentration and large volume of local anesthetic agent to obey the Fick principle of diffusion to reach the axons of a nerve if the drugs were injected or infused outside the sheath to reach the axons of the nerve. The Anderson group named this the perineurium, which is obviously etymologically incorrect, as para refers to beside, alongside, beyond, or next to. It has later been renamed the circumnerium, as the prefix circum originates from the Latin meaning around, as in circumcision. The excellent work of Manoj Karmakar and his team was quick to identify this membrane with high-definition ultrasound. First, in the sciatic nerve, as shown here, and then later in the brachial plexus, and shown by the arrowheads in this ultrasound image. I have to caution that the circumnerium at this stage of our development can only be visualized with high-definition ultrasound and not with regular garden variety ultrasound. Our Madrid group followed by showing the circumnerium microanatomically, and it was quickly realized that it forms a formidable barrier to the diffusion of local anesthetic agents to reach the axons of the nerves, because it is also formed by interlaced collagen fibers. We also showed this membrane in the higher parts of the brachial plexus. The circumneural and epineural interlaced collagen fibers are shown in green in this photograph. I have to point out here the position of the phrenic nerve on the belly of the anterior scalene muscle. Note that it is outside the circumnerium of the brachial plexus, and drugs injected or infused deep to the circumnerium of the brachial plexus would very unlikely be able to reach the phrenic nerve. We now think that phrenic nerve sparing is more a function of where in relation to the circumnerium the drug has been injected, rather than the volume of the agent. This image from the Rhina Atlas shows the white arrows that point to the circumnerium and the green arrows pointing to the epimysium around the muscles. We can easily see how an injection between the circumnerium and the epimysium in the white spaces here has a clear and easy passage or pathway to the phrenic nerve. So what are the clinical implications of this? If we look at this image from the work of Admir Hatzig, we can clearly see the free spread of contrast medium to include the phrenic nerve when injected into the space between the circumnerium and the epimysium. If it were injected or infused deep to the circumnerium, the spread would most likely have been limited to the three roots and not to the phrenic nerve. Although this is not yet proven by formal research, it is certainly been our experience over many years and many thousands of injections and continuous infusions that injecting or infusing local anesthetic agents deep to the circumnerium lead to low incidence of phrenic nerve block, low incidence of primary or secondary block failure with continuous block, and lower volumes of local anesthetic agents required for blocks. The third potentially important development as far as the microanatomy of the brachial plexus is concerned is the recent description of the circumfesicular collagen layer. Out of ignorance in our original description in 2020, we named it the internal perineurium. This is obviously a misnomer because something cannot be internal and have the prefix epi. We subsequently, in a letter to the editor of RAPM, proposed to rename it the circumfesicular collagen layer. What is unique about this layer is that it does not contain any cells. It is only made up of interlaced collagen fibers, and it snugs up right against the perineurium of the fascicles shown here in blue without any adipose tissue separating the two. As we know, the perineurium consists of cellular tissue with nuclei and thus mitochondria and DNA that can create new proteins. This creation of new proteins is regeneration, and we also now know that it is under the control of electron transfer, that is, electrical current. This is a photograph of a larger magnification of this layer shown in light green, snugged up to the blue cellular perineurium. And now we get to an area where we perhaps have to apply a little philosophy and speculation. We have to look at the groundbreaking work of Robert Becker, an orthopedic surgeon who in 1984 published this book that fundamentally changed our thinking of electron transfer in the body. He worked mainly on salamanders and frogs and was fascinated by the regrowth and healing potential these animals have. If amputated, they can regrow a limb or a tail or even parts of their heads. As we know, the impulse nerves of the brain and body are digital. We all remember the all or nothing principle of nerve conduction. Becker discovered and described an entire second nervous system of fibrous tissue surrounding nerves, which he named the perineural system. And he showed that it is an analog system of continuously varying strength, direction, and waves of strength. But Becker unfortunately died in 1989 and could not show it definitively under a microscope. This book is a must-read, but he basically concluded that this second nervous system controls growth, healing, and biological cycles. Extensive research is ongoing following this work of Becker. We always thought that fibrous tissue serves only as structural support. Becker, however, showed it also serves to conduct electrons, in other words, electricity. It has the lowest electrical resistance of all tissue in the body, and it is a semiconductor. In other words, it only allows flow of electrons in one direction. Becker never realized the fibrous sheath forming the perineural nervous system was actually bringing in electrons to change the voltage from operating voltage to a healing voltage. The big question now is if this circumfesicular collagen layer is perhaps that fibrous tissue that conducts the healing voltage that Becker was talking about. And certainly future research will clarify this for us. I again thank Professor Carmarker for inviting me to present this topic, and you will see that I slightly changed the heading. And I leave you with the thought of perhaps considering the newer microanatomy in your clinical practices when performing regional anesthesia. I thank you very much for your kind attention.